to AETCM, the emergency medicine channel. Today we'll be discussing a case of a young adult who presented with chest pain to the ER. Dr. Eben will be presenting this case.
Second list. 71-year-old man, known case of type 2 diabetes, hypertension, presented to the ER with acute onset left-sided chest pain and breathlessness. In our initial 10-second assessment, the patient was conscious and oriented to our commands. Coming to the primary survey, airway was patent, air entry bilaterally equal, there was no pooling of saliva, no increase in secretions were noted. Coming to the breathing, the respiratory rate was 25 cycles per minute, SpO2 was 85% in room air, respiratory distress was noted. Coming to the circulation, heart rate was 120 beats per minute regular, BP was 140-100 millimeters of mercury. Disability, GCS was 15/15, pupil bilateral equally reacting to light. Exposure, normal body temperature, the blood sugar was 350 milligram per deciliter. In the primary survey, we noted there is...
Before we go to primary survey, why are hemodynamics important in a patient present with chest pain?
The patient has respiratory distress. The SpO2 was less than 90%. The heart rate was 120, indicating tachycardia. And also the blood sugars were on the higher side, 350 milligram per deciliter.
So, when you say primary survey, medical case or surgical case, when you have primary survey and you come across a problem like desaturation, respiratory distress, 85%, you are supposed to give treatment at that point itself. It's not like we note it, we go on, we note it, treat it, then move forward. That is the whole point in ABCD approach. So here in airway you are told it's clear, breathing, patient is having respiratory distress and desaturation. So primarily what you can give is start oxygen, then and there itself. Start oxygen, then causes can be evaluated after primary survey, but oxygen has to be started then itself. Then when you say respiratory distress, it doesn't mean in breathing only respiratory rate, saturation and distress is noted. Lung signs are a part of breathing part. So you have a abnormality there, you should mention, do you have crepitations, do you have V's, is the patient using accessory muscles? These things has to be mentioned clearly. So were the patient having those features?
Yes.
Yes.
On examination, there was bilateral crepes that were present in the respiratory system.
Bilateral crepes in all lung areas?
Bilateral basal crepes, sir.
Basal crepes.
Coming to the primary adjuvants, ECG was taken that show ST elevation 1 AVL V1 to V4 and reciprocal changes were present.
Where?
In the
what is reciprocal changes?
In one lead, if there is a ST segment elevation, the opposite lead of the vector, there will be corresponding ST segment depressions.
Okay, so what are the concordant leads that you have in ECG? You are saying there is ST elevation, right? You told 1 AVL and V1 to V4, right? So what is 1 AVL?
High lateral leads.
No, so the 1 AVL is a concordant lead. So similarly, 2, 3 AVF is another concordant lead. 1 AVL we say as lateral leads and 2, 3 AVF as inferior leads. So concordant leads are the leads that represent the same area of the heart. Okay.
In view of tachycardia, we start giving patient with metoprolol 5 mg was given.
No, before that, ECG, why are the changes significant? What do you infer from the ECG?
ECG, there was ST elevation 1 AVL V1 to V4.
What does it signify?
Signifies that there is ST elevation MI.
Okay, so what's the criteria to call it an ST elevation MI?
To say there is a ST elevation MI, in the leads there should be more than 0.1 millivolt except V2 and V4, and in age less than 40 years V2 and V3 should have more than 0.2 millivolt, 0.25 millivolt. More than 40 years it should be more than 0.2 millivolt, and in women it should be more than 25 millivolt.
0.25.
0.25 millivolt.
Okay. So with that criteria you are saying is a ST elevation MI. Okay. how do you proceed?
This patient, the patient is having tachycardia, so we plan to decrease the rate of the patient since if the heartbeat is more, there is the diastolic filling will be less. That can lead to further complications. So first we have given beta blocker, metoprolol 5 mg was given.
Okay. Metoprolol 5 mg was given. Now, when you are presenting this case, not only presenting, when you are with the patient, you not only the drugs that you say, you have to say what and all you are doing. Initially itself, in respiratory rate, you showed there is desaturation. We don't know the cause of desaturation, but there is a desaturation and respiratory distress. You know this patient will require IV drugs, isn't it? You knew his heart rate is 120, that requires intervention. All these things, we have to do the intervention side by side. So, placement of IV cannulas, we should do in circulation itself. So when you go into circulation, if you think patient requires an intervention, that intervention should be noted there. So putting 2 large bore IV cannulas for this patient is needed because patient has desaturation. It can be n number of causes. It can be a lung pathology, it can be a cardiac pathology, it can be a renal pathology. Whatever be, we need IV cannulation. So IV cannulation should be done there. If not, when you are saying that we are giving metoprolol, route of administration is going to get complicated because this is not a OP patient or a stable patient we are talking about. We are talking about emergency. In emergency, patient may not get an IV access. So IV procurement in early stages is very important there. Secondly, you are saying that we will decrease the heart rate. It's not only heart rate. We have to see the patient as a whole. What is the position of the patient? Is the patient lying down? Is the patient sitting up? Is the patient in a proper position? That is very important there. And you are still now you haven't mentioned about the oxygen. If oxygen is mentioned, what is a cutoff value? How much oxygen will you give? How will you give? What is a cutoff value? These things has to be mentioned. So in this case, how much oxygen did we give?
We give 3 liter of O2 via nasal bronchs.
Yeah, so 3 liter O2 via nasal bronchs, which improve oxygen to this value. That has to be mentioned. So what is the aim in MI? When will you start oxygen and what is the aim?
We will start oxygen in MI when it is less than 92%.
Okay.
And our aim is to maintain around 94%.
94%. So when you say it was 85, start on nasal bronchs, 3 liter, oxygenation improved and final saturation of 94% achieved. That has to be mentioned. Okay, so it's not heart rate, BP and loading doses that we give. We have to say each and every aspect of management. So patient will be kept proper position, oxygenation started, IVHS already placed, preferably 2 IVHS. Then patient has to be connected to a cardiac monitor or defibrillator we should connect because we are dealing with ST elevation MI. ST elevation MI can develop arrhythmic complications, isn't it? So to rule out arrhythmic complications, we need to connect the patient to a defibrillator or a continuous cardiac monitoring device so that we will know the changes. Yes, so that has to be mentioned. Then
in view of decreased O2, 3 liter of oxygen via nasal bronchs was initiated. 2 large IV cannulas were inserted. The loading dose was given to the patient. Aspirin 325 milligram crushed tablets were given. Ticagrelor 180 mg and atorvastatin 80 mg was given to the patient.
Okay. Ticagrelor 180 mg you are given. What is the other alternative for ticagrelor?
Sir, clopidogrel.
Okay. What is the drug, recommended drug for loading dose?
Drug of choice, sir, it is clopidogrel.
Clopidogrel. Since we are working in Amrita, we prefer ticagrelor because of our institutional policies. Because of that we give. But drug of choice is clopidogrel. What is the dose of clopidogrel that you give?
600 milligrams.
600 milligram. Okay.
Coming to the secondary survey.
No, we haven't done that. You are given loading doses. What about the heart rate? You are given metoprolol, right?
Metoprolol.
How much did the heart rate decrease?
The heart rate came at around 80, sir.
Okay, so that has to be mentioned. What is your aim in heart rate control?
To decrease below 90 to prevent tachycardia, sir.
Okay. to prevent tachycardia, so that diastolic phase will be maintained and patient's coronary perfusion will not be affected. Fine. Along with this, what was the hypertension blood pressure of the patient?
130/80, sir.
So when you give metoprolol, it not only affects heart rate, right? It can affect blood pressure also. So when you give metoprolol, you have to say the post-metoprolol heart rate and post-metoprolol blood pressure. Because if at all this patient goes into hypotension, that is harmful for a MI patient, right? That has to be mentioned.
In view of the pain, we have given isosorbate dinitrate 10 mg sublingual, sir.
Sublingual.
What's the logic behind it?
For the vasodilatation, coronary vasodilatation.
Okay, so does that completely relieve the patient of his heart pain, chest pain?
Yes, completely. Almost completely relieves.
If at all it doesn't work,
We will go
if the
for,
patient complains of lot of pain, what is can you do?
we can give morphine, ma'am.
How do you give more?
5 mg IV stat.
When you say any drug, when you say what is the dose, how you give, that is how you should present it. So if you give him morphine, 5 mg IV stat. Morphine, according to AHA, up to 8 to 10 milligrams of morphine can be given, but in small incremental doses. So it's preferable to give 2 mg incremental doses to 8 to 10. Morphine can be very safely given in most of the patients. It will not cause respiratory depression in lower doses. So morphine is a safe drug, but MI has, certain patients with MI has contraindications to giving morphine. What are the contraindications for morphine?
Asthma, asthmatics,
Asthmatics,
hypotension.
Morphine can cause hypotension.
RVMI.
So, RVMI patients, hypotension patients, you should avoid morphine. Morphine can cause histamine release, so it can cause itching, can develop acute asthma attacks. So you can think about in asthmatic patients and all, but should be avoided in hypotensive patients and in RVMI patients. Okay. Fine. So if morphine is not being given, what are the other alternatives you can use?
Tramadol, fentanyl.
Fentanyl or tramadol you can give. Fine. What else?
Coming to the secondary survey, there was no allergic history. The patient was a known case of hypertension, diabetes. Last meal was taken 3 hours back. Patient present with complaints of left-sided chest pain, radiation to the arm, and also breathlessness was present. No history of any palpitation, vomiting, abdominal pain, syncope, edema, or PND. General examination was within normal limits.
When you're describing the pain, especially for cardiac pain, you'll have to talk about the radiation. What are the negative histories that you'll be asking? How are you going to differentiate a cardiac chest pain with a respiratory chest pain or anxiety or panic?
Cardiac chest pain, ma'am, basically it can be a retrosternal left side chest pain, acute onset radiating to the left arm or to the jaw. There can be associated sweating, palpitations can be present, and also the chest pain will be a crescendo pattern. It increases gradually, and associated breathlessness can be present that increases with exertion. And there can be also be, if the patient is going into heart failure, there can be PND, orthopnea, edema, and other features of heart failure.
So there is something known as typical angina and there is atypical angina. So typical angina is what we commonly say. It's a centralized retrosternal pain or heaviness with radiation to the inner aspect of left upper limb with radiation to back, neck or lower jaw and upper abdomen. Patient can also be associated with sweating, palpitation, syncope, and symptoms are aggravated with exertion and relieved on rest or with nitrates. This is a typical angina. Now there are atypical anginas. More than 40% of chest pain cases that presents to the emergency department worldwide presents with atypical symptoms. So when you present a MI case, having a typical angina versus atypical angina is very important because many patients may not come and give you this history. They may have vague symptoms like heaviness of chest, hiccups,
vomiting,
breathing difficulty, generalized tiredness is one of the vague symptoms in which elderly females can present. The only symptom they may say is, I feel unusually tired. Okay. Sweating alone, or even new onset cough or epigastric pain. These atypical symptoms are there. So presence or absence of these should also be considered when you say your cardiac history. Okay, fine.
Coming to the CVS examination, the pulse rate was 120 beats per minute, regular. BP was 130/80. Heart sounds S1, S2 plus, no murmurs. Respiratory system, the respiratory rate was 25 per minute. SpO2 88% in the room air. On examination of the chest, there was bilateral basal Krebs were present. CNS and GIT was within normal limits.
What does basal Krebs here in this context represent? Is it significant?
Yes, it states that the patient is going into heart failure or pulmonary edema.
In this case, when you say cardiac evaluation, not only the heart sounds, you need to look at JVP also, because patient can go into biventricular failure. So elevated JVP more than pedal edema in acute conditions, what you get is S3, which may be a bit difficult to get in a emergency setup, but look for S3 gallop rhythm, bilateral symmetrical crepitations or symmetrical fluffy shadows in X-ray to look for pulmonary edema, then elevated JVP, because tender hepatomegaly, ascites, pedal edema takes time to develop. It won't be there on an acute presentation. Okay.
Coming to the clinical impression, the diagnosis was ACS STEMI involving the anterolateral leads. Site probably will be LAD before D1 and S1 branch. It was in sinus rhythm and there were features of heart failure, Phillips type 3.
Phillips type 3.
So what's the Phillips classification?
Phillips classification, basically there are classified into 4. One, there are no features. Second, there will be S3 or bilateral basal Krebs. Third, there will be signs of pulmonary edema. Fourth, there will be cardiogenic shock. It tells us about the more of the prognosis. In one 6% and 2 17%, 3 it will be 36%.
Percentage, right. Now this patient, you're presented the case. Now how do you proceed with this patient? You have already achieved rate control, you have started oxygenation, you are given sublingual sorbitrate, morphine for pain control, given the loading doses for this patient. Now what to do?
We have to plan. Time is gold in the case of MI. The time from diagnosis of STEMI to the needle time has to be, if it is less than 120 minutes, we will go with PCI. If it is more than 120 minutes, we will go for thrombolysis.
Now, there is a difference there. It's not diagnosis of MI, it is dot to needle. So, the moment patient enters ED to the moment the PCI needle is put in the body is what we measure, not the diagnosis time, but the moment patient entered. That is dot to needle time. Now that has changed to first medical contact. In our scenario, most of the patients coming to hospital still use their own private vehicles, and first medical contact is basically door in time. But in other developed countries where emergency medical services and ambulance services, transport services are much better developed, it is first medical contact. So that decreases the time to react that much less. So we need to be on high index of suspicion. Now, this patient decision for PCI is needed, true, but right now whenever we say ABCD, it's not a one-off criteria. There is no primary survey done once and forget it. It's always about do reassess. So you are given these drugs. Now you have to reassess and see what effect did my management did to the patient. Is the patient better now? Is the saturation improved? Is the respiratory distress improved? Is the crepitations decreasing? Is the chest pain still present? These are very valid questions, because MI is not a disease that can be treated with drugs alone. you either need to thrombolize or taken for PCI. Unless either of these two are not done, patient will deteriorate. So even if you are given loading dose, it's not going to improve patient's condition right now. So already you have a patient who came in early pulmonary edema. He was having desaturation, bilateral crepitations are there. You are given loading dose. But what have you given for the pulmonary edema? Except oxygen, we haven't done anything, right? But you need to do something. What do you want to do?
We can give injection Lasix.
Yeah, furosemide, loop diuretic you can give. Okay, so loop diuretic bolus dose you can give. Did you give that?
Yes, sorry.
Okay, how much you can give here?
80 mg was given.
80 mg furosemide loading dose can be given. Along with that, we can start furosemide IV infusion also for this patient. If that is given in 30 minutes, when you reassess, patient should be better. If not, if in reassessment patient still having desaturation, he is still having respiratory rate more than 24, is still having respiratory distress, what will you do next?
So we will suspect whether there are any pulmonary embolisms.
No.
What we're saying is, if at all patient's work of breathing increases, you've given furosemide, that is all right. But let's just say patient has increased tachypnea, increased respiratory distress. What are you going to do? How are you going to tackle the increased work of breathing?
Yeah, so you need to give positive pressure ventilation, non-invasive positive pressure ventilation. You can try that out. If not improving, we have to go invasive. Invasive is basically intubation and mechanical ventilation, but before that, non-invasive positive pressure ventilation. Bilevel positive pressure ventilation is very good for cardiogenic pulmonary edemas. So you can initiate the patient on that. Okay. So that reassessment is very important there. Then what else?
When you're going to put the patient on a non-invasive ventilation, what are the things that you're going to keep in mind? Huh?
Deep blood pressure.
Okay, it causes hypotension, plus we're giving furosemide, we're giving metoprolol. All of this can cause drop in blood pressure. So you're going to keep in mind hemodynamics. Then?
The tidal.
No. Basically, you will see if the patient has achieved full sensorium or not. Because the patient has an altered sensorium, then BiPAP is going to further worsen the patient's condition. Then, and if the patient is in full conscious oriented and is also understanding, then you will have to first explain to the patient before you secure a mask on the patient. You will have to first explain how this whole thing works and then see if the patient is cooperating with the machine. So there should not be any asynchrony between the patient and the machine. So we will keep in mind all of this, and apart from this, you will make sure that the patient has attained full or proper mask seal. Okay, so these are the things that you will take care before you start the initiate BiPAP on a patient. Then, what else? How else are you going to approach this case? You've dealt with respiratory part. You're going to frequently reassess the hemodynamics. You have given the loading doses. You've dealt, and then you keep asking about the pain score of the patient. Then what do you know about heart score?
Ma'am, heart score, it is useful for atypical chest pain for the risk stratification.
What scoring for prognostication will you use in this patient?
This is a typical or atypical chest
typical chest pain.
STEMI, right? What is the score that you will use?
ABC.
You can use either Gray score or TIMI score. TIMI score or Gray score is what you can use for these patients. Now, since we are a cath lab having institution, we have called cardiology and they took the patient for primary. If not, if you are in a peripheral center, this patient is there, you are given this much management, what else can you offer the patient?
So we can do thrombolysis and then ship the patient within 6 hours for PC.
Okay, so if you can't refer the patient to a PC enabled center within 120 minutes, then the safest thing that should be done is to thrombolyze the patient and then only shift the patient. What is the drug of choice?
Tenecteplase.
Tenecteplase. What is the FDA approved drug of choice?
Streptokinase.
Alteplase. Okay, fine. So alteplase is the drug of choice, FDA approved drug of choice, but ecteplase is nowadays used, and most commonly available drug is streptokinase. Yes. Okay. Anything else?
ECG changes apart from ST elevation. What other ECG changes will raise an alarm that this can be an MI? One is ST elevation. Apart from ST elevation, what else is equivalent to being called as an ST elevation MI? The same grade you will do it all over again if you see another ECG change. What is it?
New onset.
A new onset LVBB is again, it has to be considered as an ST elevation MI.
Not a old one. New
New
onset
onset
streptokinase.
LVBB.